Hello and welcome to today's webinar, How Community Health Workers and Promotores Can Support Individuals with Complex Needs Amid COVID-19, hosted by the Better Care Playbook through support from the Seven Foundation Collaborative. Before we get started, I'd like to go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question and online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on bettercareplaybook.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Logan Kelly, Senior Program Officer at the Center for Healthcare Strategies.
Thank you so much, Travis, and welcome everybody to today's webinar. I'd like to again thank the Seven Foundation Collaborative for generously supporting today's webinar. And today we're excited to explore how community health workers and promotores can help to support individuals with complex health and social needs. Before we dive in, we'd like to learn a little bit more about who is joining us in the webinar today. So right now you'll see a one-question poll pop up on your screen. Please let us know which of the options on your screen reflect your main interest in the webinar, and we'll then share the results. Next slide. So for today's agenda, after some brief introductory remarks, we'll hear more on the roles of community health workers and promotores in the pandemic, and how this workforce strengthens the health of the communities that they serve. Then we'll hear about considerations for program implementation from the perspective of a leader of a program that has been nationally implemented, as well as a case study of a New York City health systems approach to building community health worker programs to address community needs during the pandemic. And then our presenters will answer questions submitted by all of you during the webinar. And again, if you have a question, please submit it anytime by clicking on the Q&A icon located at the bottom of your screen. So now I think we're excited to see the results from the poll. I think we can end that. Great, so amazing that we have well over 700 participants and looks like 550 people took the poll, and well over 40% identify as community health workers and promotores. We're so excited to have you all joining us today on the call. And just looking through these results, we see a lot of interest in policies related to this workforce, a lot of interest in developing, refining, or considering these programs, and from individuals who work with community health workers and promotores. So thank you all for joining us. We're excited to learn a little bit more about what brought you here today. So next slide. As you'll see, we are really fortunate to be joined by a terrific group of speakers and leaders today. First, we'll hear from Maria Lemos, the founding executive director of Fusión y Compromiso, which is a California-based organization that provides leadership, capacity building, and advocacy for over 4,000 promotores and community health workers. Next, Dr. Shreya Kangovi will present on implementing community health worker programs. She's the founding executive director at the Penn Center for Community Health Workers, and developed the IMPACT program, which is the most widely disseminated community health worker program across the US. And finally, we'll hear from Dr. Robert Fields, Senior Vice President and Chief Medical Officer of Population Health at Mount Sinai Health System in New York. And he'll describe how this health system has partnered with community health worker organizations and how that partnership has evolved during the pandemic to meet community needs. Next slide. Oh, next slide. Perfect, thank you. So I'll just provide a quick overview of the Better Care Playbook, which is an online resource center for evidence-based and promising practices for people with complex health and social needs. The playbook is a place that summarizes the latest research. It shares actionable implementation guidance and provides first-person perspectives on improving care for complex populations. We've posted a number of resources on community-based workforce strategies, and we're really excited to be posting a number of new resources and implementation tools on this topic in the next few weeks. Those resources will all be posted on the Playbook's website, which is bettercareplaybook.org, and distributed through our monthly newsletter. The Playbook is coordinated by the Center for Healthcare Strategies, through support from 7 leading national healthcare foundations. Next slide. So there are a number of different definitions and titles used for the community-based workforce, but core to each of them are serving as frontline public health professionals who bring a close understanding of communities. Their work to connect healthcare, social services, and the community is strengthened by their shared lived experiences with the communities that they work with, and that really enables high quality and culturally relevant service delivery. Titles for this workforce may vary. Some of the most commonly used titles are listed here on the slide, and our speakers today represent organizations that use different titles. In this webinar, we're primarily using the phrase community health workers and promotores throughout. Next slide. Community health workers and promotores also may take on a number of different roles, and that depends on the environment and the focus of the programs where they work. These roles can include being care team members, working in partnership with healthcare providers on care coordination, helping individuals to navigate health and social services, providing screening or health coaching, facilitating enrollment in available services, advocating for clients, and providing preventive services. These programs are run by health systems, clinics, including federally qualified health centers, community-based organizations, managed care plans, and government public health agencies most commonly. Next slide. And a number of evaluations and studies have found positive outcomes from interventions that involve community health workers and promotores. The CDC conducted an evaluation of these programs and found strong evidence that they improve health-related and social outcomes. And additionally, studies of specific programs have found positive outcomes related to reduced hospitalization, as well as financial return on investment. And we'll hear more about those outcomes shortly from our presenters. Financing these programs has been an ongoing challenge as community health workers and promotores have not generally been a part of the way that healthcare is paid for in the United States historically. Many programs are grant funded, which can be difficult for program sustainability. Some programs may be funded by managed care contracts or by health systems. States can also develop Medicaid state plan amendments to expand the authority for community health workers and promotores to deliver services. And some states have also expanded this workforce through Section 1115 demonstration waivers. According to the US Bureau of Labor Statistics, there are only 59,000 individuals classified as community health workers, a small number compared to other health professions, as the gaps in funding have historically limited how this workforce has grown. Next slide. And our speakers will really be speaking in much more depth about these points, but as we know, the COVID-19 pandemic has led to increased needs for healthcare and social services, including behavioral health care. And there's a significant need for public health communication and culturally sensitive health education. And the pandemic has also disproportionately affected communities of color and has exacerbated health disparities. And within this context, there are very meaningful opportunities for the community health workforce to address the long-term impacts of COVID-19 and of systemic racism for high-risk populations. And I'll call out a blog post authored by Denise Smith, the Executive Director of the National Association of Community Health Workers, that's noted in the reference to this slide, which speaks more in depth on a number of strategies for the community health workforce to address these impacts. And our speakers today will be sharing strategies of how programs are building the capacity of communities to respond to the health and economic impacts of the pandemic. These lessons are really highly relevant for community-based organizations, health system leaders, health plans, and for policy audiences who are interested in how community health worker programs can be established and expanded to mitigate the negative effects of COVID-19 on high-risk populations. Next slide. So with that, I'm very excited to welcome Maria Lemos, who is the founding executive director of Visione Compromiso, to speak on the role of community health workers and promotores amid COVID-19.
Thank you very much, Logan. Thank you for the introduction and welcome everyone to this webinar. I'm very excited to be here and to share the work that we've been doing for 20 years. As you can tell on the left corner, this is our 20th year of Visión y Compromiso. And we started with a small group of us who wanted, promotoras, who wanted to share information and provide resources to our community. And we started to come together with 5 of us, and we've grown into thousands of promotoras across California and other states, developing curricula, providing information, and really centered on health equity, social justice, and really an authentic collaboration with who are promotoras and community health workers and community leaders. The network really believes in a socio-ecological model that everything impacts us. And I show the pictures of some of the promotoras in the network, both men and women, although the network, and I would venture to say that the majority of promotores are promotoras, are women. At least in our experience, 95% of our network and 90% of the work that and the people that we train are women in the community. And we're very diverse. So the pictures that you see are not only diverse in age, diverse in countries that they come from, but also diverse in the relationships they have with organizations. Many promotores, when we started, promotores are primarily volunteer. And through the evolution of the promotor community health worker discussion, we have included promotores that work in and are affiliated with other organizations. So promotores come from Girl Scouts, from domestic violence, from resource centers, or they're volunteering with their faith organizations. The world of promotor is very diverse, and it's not necessarily public health centered. And so I really want to acknowledge that the promotor world is vast and deep. And so we are across urban and rural areas in Mexico also and in Guatemala. And the history of the promotor model comes from many other countries. You have barefoot doctors in China, you have promotores, or the language that they use, in Russia, of course in Mexico. And there's a historical reference to the work of the promotor and the importance of it in their communities for many, many years. It's new to the United States. In the 60s, we really started looking at the community health outreach worker, the child, during the AIDS epidemic in the 80s. And so it's just really, I think, fairly new to the United States. We have a skilled team in Visión y Compromiso. We're bicultural trainers. We develop curricula. We're program managers, we're community educators, and we're workforce development specialists. So I'll talk a little bit about workforce in the next slide. We also work with clients that include hospital health plans, local governments, and we have moved from a space of the network into project development. And we started that probably 10 years ago when we were asked to look at the integration of the promotor model in covered California. And we wanted to show by example that promotores can do and learn almost anything. They may not have a college degree, they may not have a high school degree, and they may not speak fluent English, but they are the most important persons in our community. If we can go to the next slide, please. So here is an example of our philosophy and what we're centered on. We believe that a promotor has what we call espíritu de servicio. It is that individual that has that spirit of service, that they will go out and they'll serve, they'll help their community, they'll help the frail, they'll take food, they'll bring resources. In my history, that was my mother. She was the promotora in our community. I grew up knowing that our family was always helping, always giving, and it was a cultural tradition. What we believe is that if we continue to give support, information, and education to the promotor, to that person, then their experience and their knowledge and their base expands. They transform themselves. Then they influence their family and they influence their community. And that's where we come to the community transformation model. Over 20 years and thousands of men and women that we've trained, we've seen that personal growth, that family growth, and especially the community growth and the awareness. This person that we have here is Maria Luisa, who came from Mexico. She was a nurse, and she didn't get licensed here in the US, so she worked in the fields in the Central Valley. She always gave of herself. She was an example of the promotor de espíritu de servicio who would go out. She was a leader in our biblioterapia program, which I'll speak of a little later. She gave classes. She was always absorbing as much information so she could take it to the community and share it in informal ways. She would drive miles to the rural areas. I remember visiting her in this rural community where she was training and teaching promotores 7 to 9 o'clock in the evening after they got off the fields. And that kind of dedication is something that promotores do. They're committed to their community and they want to help. They don't always get paid for it. A promotor is often a volunteer, but we certainly through our workforce piece want to encourage payment. Unfortunately, Maria Luisa passed away a month ago from cancer. But one of the memories I have of her is we hold an annual conference of 1,000 promotoras. This year it will be virtual in October. And in our conference, the weekend before our president was elected, we held our conference, and she is Samoan and Mexican descent. And she teaches hula to farm workers. And at that conference, she and a group of hula dancers danced hula to God Bless America. And if you can imagine the emotion that came with that, the commitment and the love for America, whether they were residents or citizens didn't matter. It really was the love for this country and wanting to be here and provide a better life for their children, which is the essence of who our immigrant community is. If we could move forward, please. I wanted to share a little bit of some of the programs that we have and some of the work that we do in really impacting adults with complex health and social needs, and especially those with multiple conditions. And this is an example of one program that we have. We have combined Me Veo Bien, Me Siento Bien, which is a program that was developed by a farm worker in Napa when we started training with him. And he said, Me veo bien, me siento bien means I look good, I feel good. And it was kind of a running joke with us. And he would say that he went through our training, he understands diabetes, he's eating better. He's developed a system where he now has focused on eating fruits and vegetables, drinking water, really cutting fats, carbs. And so he wanted to share that with people, and he developed this little tiny curriculum. We then helped him develop it into a full-scale program that's called Me Veo Bien, Me Siento Bien. And you can see in the middle section where they are learning about food, nutrition, and then the exercise pieces. 10 years ago, we developed an exercise program called biblioterapia, which is more than exercise. It's really wellness and emotional wellness tied into it. It's community-driven. We certify the instructors. We carry their insurance, and they can provide these resources anywhere in the community. It's very popular. We must have 400 trainers across California, Nevada, and in other states, and now in Mexico and Guatemala. And it's free to the participants, and it's in their neighborhood. And these are two examples of how community is able to develop programs that will support wellness and healthier lives for our community. Especially in areas where there's little resources, where they really can't get to a clinic or a hospital, or they have long wait lists for appointments. This really, I think, these slides to me and these two programs stress how community has always been able to develop resources. They're not formal in the sense that they're formal programs through us, and certainly we get funding for them, and we've expanded them across California. They're not evidence-based. Evidence-based process is a very difficult process to complete, but they are community practice. And I would encourage those of you listening to the webinar to look at community practice in your neighborhoods. Community-based organizations for a long time, and promotoras have been developing programs that are useful and relevant to the community with very little resources. I'm amazed at how much we're able to do with very little money. There's a saying that we have at Visión y Compromiso, con dinero y sin dinero. With money or without money, we will see that it happens. And we also say the social change doesn't happen because you have a grant. Social change happens because you've been able to develop the leadership and the capacity of our promotores in those areas to understand the systems and to be able to work within those systems to better, to provide better service to their community. These programs are really important because they support ongoing disease management and treatment compliance through the education and the support systems that these two examples give. They reduce risk and promote positive changes in health behavior, as Don Jesus showed. He changed his lifestyle, and he used to, it was kind of ironic because his part-time job was he used to cook chicharrones at a local market. If you know chicharrones, they're very unhealthy, but they're wonderful tasting. And so through his education process, he left that and he's now doing these trainings. And he, by example, he encourages and he shows that these changes can happen. As an older adult, he knows how important it is. And we continue, he's now training with us and he continues to show that it's never too late to change your behavior. It's never too late to eat healthy, and that you can reduce your blood pressure and your A1C through some simple techniques like this. The next slide, please. Thank you, Travis. Here we talk a little bit about what is it that we're doing in COVID. The coronavirus has affected everyone, and most dramatically, if you look at the data across the states with the highest incidence of coronavirus, the Latino community is being hit the hardest, certainly in California and some of in our rural areas and in Los Angeles and the Bay Area in particular. And so what we did as soon in March is we started doing a series of webinars. We have 10 that we have put on. You're welcome to go to our website and see what they are. They're all in Spanish. And it started with the definition and really what is coronavirus, what is COVID-19, what are some of the techniques really supporting. And then we started going into really some other wellness areas. At this point with people, especially promotoras, losing their jobs and our communities being without employment, scarcity in food, access to resources, and really in dire need. And the webinars, the virtual support that us and other agencies are giving is a tremendous resource to them. And so now we're into wellness and really looking at talking about webinars with parents and children, we're going to be moving into how to support parents to support their children in education, as many schools are not going back to school. Caregiving, we have webinars on caregiving and older adults. We have webinars on suicide, believe it or not, and racism, and how is it that that's affecting our interaction with others in our community. And these are webinars that then topics that individuals want to know about. They're not getting that information anywhere else in a language that they can appreciate. We're also working with our indigenous community and providing support to them. In California, we have several indigenous communities, most notably the Mixteco and the Mayan. And so we're working with our partner organizations to support them in getting information out in a timely basis. We're also actively involved in sharing community resources and in advocating. We have a legislative day where we take our advocacy committee to Sacramento to walk the halls, whether they're residents or they're citizens. And that's an important piece in terms of actualizing the needs in your community. We believe that advocacy at the local level, whether it's with the school board or it's with your principal at the school or it's the health department, really identifying what those local needs are and building the capacity of us to engage in that conversation. My mother was a promotora. She wanted to, I remember her wanting to speak to even my teacher, and she couldn't because she never, to the day she died, she didn't speak English. But she did communicate through somebody else, and it was important for her to articulate what our needs were. And that's a very important piece for promotores and community to engage in. And I want to highlight that promotoras right now are really experiencing the same lack of jobs, the same unemployment, the same food insecurity. I mentioned it earlier, but it's really prevalent, and it is a desperate situation for the Latino community with little resources. We are the essential workers, and some of us are working, but many of us are not, and we're not able to benefit from employment at this time. The other thing that we're doing is really talking about information, medical applications. We have a campaign going for wearing masks, social distancing, and hand washing. We believe that we have to be participant in that right now, and so we are partnering with our other organizations as well as our network of promotoras across the state, and in other states we're partnering with other informal networks to really get the word out and to say this is something that's critical to our community. Let us make this a priority. And we're using the same technique that we're using in Nevada, which is a summer without sugar. It's a really great campaign where promotoras are speaking on the web and doing presentations talking about ways that they can drink water. Agua with cucumber, agua fresca, agua with different things, so that we move away from drinking sugary drinks during the summer. We'll use that same technique for masks and hand washing and social distancing. It's a community effort, and I think we really want to support that. We really want to advance the community is the next phase during the pandemic, that it's important for us to look at community as partners. We say that going to scale means partnering with community and community-based organizations. We are part of that movement by supporting the capacity of communities, by sharing information, by building out some of the webinars and sharing. We're training other organizations and promotoras on, for instance, on charlas, which is informal support groups, and really having a venue where people can come together by phone or by video. Everything we do is now virtual. And it's amazing how quickly promotoras are able to grasp onto the virtuality. It's very successful. We still do phone banking. We still do communicating in places where we must meet, like markets and places like that. But we really support that. And we encourage those of you listening to move outside of the realm of the public health service, the hospitals and the county systems and the health plans, and look at how to engage with community. There's an army of promotoras out there across different sectors, ready to engage, ready to support community. And I think that what we have shown by examples with the 30 projects that we work is that promotoras can really learn most anything. And how is it that we can support them in taking that out to the community, especially right now when resources are scarce with the pandemic. Travis, if you would go to the next one. Here, our vision is Hacia una vida digna y sana, which is really working towards a dignified and a healthy life. And that's important, the way that we have actualized that. And for us, it's the dignity part is important, because we never want someone to feel that they're not worthy of health, of having a healthy life, of education, of a future for their children. Like my parents came here from Mexico many years ago, wanting a better life for their children. I grew up as a farm worker. My mother cleaned houses. I grew up in a very modest environment. I still remember working the fields in apricot and grape. But I'm blessed to have an education. I went to college, and I'm very fortunate to have done that. And I remember my mother always saying, I don't want you to work as hard as I work. I want a better future for you. And that's all that anybody wants, I believe, for their children, whether we're African American or we're East Indian or we're Mexican. Our parents want that for our children. And so what we have developed to build that capacity at the community level is a Promotor Institute. We're expanding our community transformation model, which is building the personal and the community capacity to engage in this work. Base building. We have an army of promotoras, as I mentioned, who are ready to engage. We've been training for 20 years. We know that they're out there. And the advocacy piece. And this has led us into workforce readiness. So we believe in the integration of the promotor model and workforce. And so we provide technical assistance to agencies to understand the model and to see how they can adapt it for their organization while we're concurrently training promotoras in that path to move towards employment, if they choose to. So they can be the best promotor with all this knowledge and information in the community, or they can apply for a job and work for an agency. We do believe that a job is going to make the biggest difference in changing social determinants. If you want to change how you eat, how you travel, where you live, the support that you have, a job is the best way. And so we're really working on it's an intentional movement to move into workforce development. I think that's a summary of what I have to say. And this lady that you see on this slide, I like it in particular because there's such a positive note of who we are. Promotores are thoughtful, and we just want to be part of the solution in our neighborhoods, in our cities, in our counties, and in our states. And I hope that you look for us working towards a dignified and healthy life for all. My information is here. I invite you to join us, to go to our website and join us in some way. So thank you, Logan.
Thank you so much, Maria. It was really wonderful to hear about the tremendous work that you and Visione Compromiso have done. So thank you again. Next, I'm pleased to welcome Shreya Kangovi, Executive Director of the Penn Center for Community Health Workers, who will share insights on program implementation.
Thank you so much, Maria, and thank you so much, Logan. What I want to do just to start our conversation is just make sure that we understand the big picture and the framing around what causes health inequity. The root cause of health inequity is racism and classism and other forms of social injustice. And those are psychological diseases that affect the privileged. Even though they afflict the disadvantaged, the root cause actually starts with people who are privileged not wanting to share resources. So I just want to name what the problem is that we're trying to solve, because sometimes we get things twisted and we focus on the victims of structural violence without necessarily naming the creation of it. So, you know, the root cause is these types of discrimination, and that affects, it translates into public policies, which affect the distribution of wealth and power across society, and that affects living conditions, and that affects people's behaviors, things like exercise or smoking, and then that affects health and creates disparities, whether it's within COVID or diabetes or police violence. So I think, you know, we are all kind of familiar with this on an intellectual level, but it's important to start the conversation by naming that. And I think the reason I really appreciated Maria's comments, because she was able to highlight how community health workers can intervene at every stage of that trajectory. Yes, they can, you know, downstream help individuals you know, with their diet and exercise, and they can, you know, move upstream a level and focus on employment and access to healthcare. But it's also really critical that they have legislative day where they're actually influencing policy. And either they're further upstream, there are some really exciting programs, for example, in St. Louis, Missouri, where community health workers are doing anti-racism. They are actually teaching police officers, for example, to be less racist. Or in Philadelphia, we have a program where community health workers teach healthcare executives about cultural humility. So that's an important kind of big picture framework that I wanted to start off with. Let me introduce a little bit about my organization, the Penn Center for Community Health Workers. Our mission is to reduce health inequity through effectively hiring, acknowledging, and empowering community health workers. And we do that through 3 sets of activities. The first is science. When we started doing this work about a decade ago, we did it with strong, formative, community engaged science. What we did was actually, you know, myself and my colleague Tamala Carter, who's a community health worker born and raised in Southwest Philadelphia, went out and interviewed about 1,500 people. These are individuals who live in communities that are disadvantaged, and we talked to them on porches, on bedsides. We asked them what makes it hard for you to stay healthy, and how should we design a solution. We used all of that input to design Impact, which is a standardized way to hire, train, and deploy community health workers that I'll talk more about in a moment. We then tested Impact in 3 separate randomized control trials and found that it actually does move the needle on things like access to care, quality of care, mental health, reducing hospitalizations, and has that return on investment from our CT data of $2.50 for every dollar. That has enabled some scale, both locally and nationally. In the Philadelphia region, we have a direct care program where we have about 70 full-time employees, most of whom are community health workers, and we continue to serve our community. We also support a growing national network. We have partner organizations in about 18 states, and these are all different flavors of organizations: public health, healthcare, community-based organizations, and we essentially support them in either building or optimizing their community health worker programs so that they're local, they're very kind of self-determined, but they're drawing from some of these evidence-informed best practices. And increasingly, we have been paying a huge amount of attention to standards, policy, and financing, because as Maria and Logan pointed out at the top of the call, those are the bottlenecks. So with that very high level overview, I want to get right down on the ground and really kind of set the stage for what's going on in many of our hardest hit communities. And I want you to think about a woman named Maggie, and just imagine that you're Maggie, you're a 46-year-old woman from Southwest Philadelphia. Let's say that you work in retail, and since the COVID pandemic, you have lost hours. So you're having trouble making ends meet, and you have a landlord who is breathing down your neck. You're trying to support your aging mother and your teenage son. And, in between all of this, you have asthma, which you used to have under good control, but your doctor switched to televisits, and you don't have internet at home, and you don't have a fancy smartphone. So you've been digitally stranded, and you've had to end up in the hospital a few times because of your asthma. In between all of this, when you do get to work, you are pushed around by your 22-year-old white manager who treats you like you are less than because of the color of your skin or because you don't have a lot of fancy letters behind your name. And in the back of your mind, you are worried about your son getting stopped by the police on his way home from school because you have seen, as all of us have, a Black man have the life squeezed out of his body by a white police officer. And then on top of all of this, you get a call from a contact tracer saying that you've been exposed to COVID. This is life in our communities. And if you think it's any different than that, unfortunately, that is the reality. It's incredibly, incredibly heavy. And that just illustrates that, there's not just one cause of death or disability in our communities. The root cause is injustice, and it manifests itself in all of these different ways. So how do you support somebody named Maggie? Well, I think that's where community health workers really come in. And so now imagine a community health worker named Rochelle. And just know that Rochelle comes from a similar background to Maggie. She knows what it's like to have to live check to check. She knows what it's like to face discrimination. And so she's been there. She understands that. And she reaches out to Maggie right now virtually because of the COVID restrictions. In the past, you would have met her face to face, but she reaches out via the telephone, and she gets to know Maggie. She doesn't tell her what to do. She doesn't talk at her. She listens. And she says, Maggie, things are crazy right now. I just want to see if I can help. But first, is it okay if I just get to know you as a person? Tell me your life story. So she learns about Maggie, her strengths, not just her deficits, all of the things she's proud of, all of that she's done, and also the challenges that she's facing right now. And she asks Maggie, what do you think you need in order to improve your life and your health right now? We never ask that in healthcare or in public health. We always tell people what to do. But Rochelle asks Maggie, what do you need? And then they do those things together. Rochelle drops food off on her porch. She advocates with her employer so that she can get time to self-isolate. She helps her to battle that eviction notice. She helps connect her with a doctor who just does telephone appointments and doesn't need all of the fancy telehealth. And she may be involved with a collective advocacy effort that's going on in her community where she is, helping the city council to divest from police or retrain the existing workforce so that they are less racist. She is operating on all of those different levels. That is the real magic and power of this workforce. We sometimes are reductionist when we talk about community health workers. We talk about, okay, they're care coordinators, or okay, they're going to screen and refer somebody to a food pantry. And that is, they are much more than the sum of their parts. You know, the story of Rochelle is magical, but it is not accidental. And that is because Rochelle herself, in the impact model now I'm talking about, was hired using specially designed hiring guidelines that allow us to identify natural helpers, people who not only have that shared life experience, but that loving and service spirit that Maria talked about in her remarks. And you can actually do that at scale, and that's something that we have really done a lot of work on. The questions that she asked when she got to know Maggie were not accidental. They came from a playbook that we developed after interviewing all of those patients, but also after scouring the social and behavioral science literature. Rochelle documents her notes in an app that we co-designed, as we co-designed all of this with community health workers. And that's where she can put all of her notes. That's where, you know, it connects with the electronic medical record or other social service platforms, and her performance and service to patients over time can be assessed. And she receives structured supervision from a supervisor or manager whom we have trained using our interactive online training platform. So all of these elements and more are kind of what we need to think of as a field for doing magic, but doing so with fidelity and consistency. This is sort of the package, you know, just a piece of the package that we called impact, that we tested in these separate randomized control trials, which have demonstrated these results and have had this return on investment that, you know, in reality, it does carry a lot of weight. And I think that's an important piece that we've been able to demonstrate, that if you structure these programs well, you set community health workers up for success, and they can do these really, really incredible, they can move these outcomes. So what we want to close on is just talking about, you know, besides our specific technical assistance program, you know, what can we be thinking about as far as standards and scale for this workforce? And I think when a lot of us talk about standards, we tend to think about training and certification of individual community health workers. And while that is important, that is, you know, not sufficient, and it actually may have some downsides that I want to quickly touch on. When you look at community health worker programs over the past several hundred years, because as Maria pointed out, they are not new, there are some core elements that are tied to the performance and the success of the program. It's not just how community health workers are trained, but rather how they are hired, whether and how they are paid. I mean, I absolutely believe that community health workers need to be paid and paid fairly. Supervision, staffing ratios, you know, you all on the line who are community health workers know that you cannot do your best work, you know, do what Rochelle did for Maggie if you have caseloads of, you know, several hundred patients. It's just not possible to do that. There needs to be some good playbooks and workflow that is grounded in social and behavioral science. There needs to be consideration about documentation, quality control, keeping the workforce safe. So all of these infrastructural elements actually are the things that not only drive the outcomes that we're all looking for, but create fair and good working conditions for this workforce. And so what we're doing in collaboration with the National Association for Community Health Workers, NCQA, and a number of other organizations across the country is that we're translating a lot of these elements into standards, not just for community health workers, but for their employers, because they're the ones that control the purse strings, and it is their obligation to create a work environment that sets community health workers up for success. Finally, in terms of policy and financing, we, again, along with a number of partner organizations, including Health Leads, Health Begins, NACHWA, APHA, have been very vocal around this is the time, you know, the stage is set for scale, but we need to have financing. We have the science, we have the workforce, we have the history behind this, we're gonna have standards. We need the money, and community health workers need to be paid through Medicaid. So we are very excited because this is starting to have traction. I'm sure a number of you saw that Vice President Biden included our recommendations in his recent policy proposal. Again, that is for funding community health worker services, not only directly as part of emergency COVID response, but also in long term as an optional Medicaid benefit. And this is really critical. And we have to keep pushing on this, and we have to make sure that the funding is not just for these very narrow slivers of who community health workers are and what they do. This can't just be, okay, community health workers do diabetes education or community health workers do contact tracing. Because again, as I started, I'll close by saying that is not who community health workers are. They are whole person, grassroots, and they are able to address all of the different stages of inequity in health. And so that's what this type of funding would allow us to do, is to be able to actually pay the workforce for the broad range of social support, advocacy, navigation that they are able to do, and do so in ways that are tied to high quality standards. I'm really looking forward to your questions and answers and discussion. And this is my contact information. So really, really excited. Thank you so much.
Thank you so much, Shreya. We've received a lot of great questions already. We will do our best to answer as many of them as we can. And please, if you have questions for any of our presenters, please share them by clicking on the Q&A button at the bottom of your screen. And I'll note that we are posting both the recording of the webinar and the slides, so you'll be able to view this or share it with colleagues. And again, please share your questions. So next, I am pleased to introduce Rob Fields, Senior Vice President and Chief Medical Officer of Population Health at Mount Sinai Health System in New York City. And he'll present today on health system approaches to building partnerships to expand the role of the community-based workforce.
Thanks, Logan. And I know we're slightly behind in schedule, so I'll try to be as efficient as possible here. So as mentioned, Rob Fields, I'm a family physician and Chief Medical Officer for Population Health at Mount Sinai. And I'll give a shout out to community health worker colleagues that are on the line from Air NYC here in New York, who we have started our journey with or trying to evolve our journey with them in some of the case examples or in use cases that are described in here are related to our work together. So I appreciate them being on. Okay, so very quickly here, Mount Sinai itself is an 8-hospital system, but our network actually spans beyond the hospitals. We have approximately 4,000 physicians, both independent and employed physicians, and we manage in our population health managed care contracts, getting close to 500,000 lives in various stages of financial risk. And I highlight that primarily because we see our work with community health workers as a really important part of that strategy in managing the clinical and financial outcomes of the patients that we manage under those contracts. We are early in our journey. So what I'm trying to describe, or what we'll describe here in the next couple of minutes, is not a fully evolved strategy. We are sort of humbly moving forward and learning as we go and doing our best to work with our colleagues to adapt and evolve and learn and be as tight in our partnership as possible. Having said that, our managed care strategy and our move to risk, for me, is as much of a social justice move as anything else. I think I was an independent practice in primary care in Western North Carolina for many years. And one of the motivators to do what I do today is really, I speak Spanish and served probably about half my day was serving Spanish-speaking folks in rural North Carolina, and realized that was very quickly an independent practice that was not a financially sustainable model, unfortunately. And it seemed grossly unjust that the healthcare financing structure that exists within the US, if you can call it that, serves really to do more to patients and not get to clinical outcomes and not to serve those that need it the most. So those that needed my care and primary care and other types of care had the most difficulty accessing it. And so I think given in the absence of a single payer system or a different financing structure, I view Pop Health as a means of changing the paradigm instead of from a widget-based financing model of healthcare to something that looks at total cost of care and then incentivizes upstream interventions around social determinants and community-based approaches in a way that then makes things financially sustainable for everyone involved. So that's sort of the path that we take in our philosophy in evolution here at Mount Sinai. And I put this date on here I'm back in the office in New York City for only the second time since March. So March 17th, I still actually have the calendar on my desk. From March 17th was the last day that we were in the office because that's when everything within Sinai officially just turned upside down in terms of COVID, and everyone is aware of the numbers and the impact within New York City for how that went down. But operationally, I think it's important to think about how health systems think. So we immediately started to consider that the normal way that we manage chronic conditions and serve our most vulnerable patients was no longer going to be in person. It had to be in a remote strategy. But there was a fair amount of fear in the community about what it means, and then education and engagement of how to get vulnerable patients connected to care. And so we couldn't depend on the typical sort of passive models of waiting for patients to call and make an appointment and come in and be registered in the typical sort of way. We had to do even more outreach than we typically do. Our front desk folks needed to quickly convert to calling registries of patients, especially our most vulnerable folks, to make sure they had what they needed. And so on the pop health side, we developed a strategy to help codify that through the system. And there were various other impacts. In just flipping through this pretty quickly, just given time, there were impacts all over the community that are not unique to New York, but certainly were true here. Our safety net practices, either within our own system or FQHC partners or community-based partners, were really at risk financially. Many of them laid off staff in the midst of this, and many of our independent primary care practices closed. And so it created a major access issue for many of our patients. Our care managers were identifying unbelievable rates of food insecurity issues, behavioral health issues, because of the immense amount of financial, social, emotional stress that was occurring in a pretty rapid fashion throughout the city. And it just exposed a lot of the vulnerability and the lack of capacity that we had throughout the city. So when we started to think about that, we needed to create a structure and increase or enhance our partnerships with community-based organizations in order to do the type of outreach that we needed to do at scale. So we obviously, as a population health entity, we have a small army of social workers and nurses that do outreach, but normally for exceeding like the top of the risk pyramid, the highest risk folks, when in the midst of COVID, we had to outreach to so many more people than we normally had, than we were staffed or were able to do. And it required a fast forward of an already evolving strategy on how we use partners, including community health workers, to help us do that outreach, identify high-risk people or people that were newly in need, that may not have been identified as high risk because they had appropriate infrastructure yesterday, but today, because they lost their job or because they had family members ill, or because home health stopped coming, or all the normal infrastructures were gone, we needed help in identifying those folks quickly and connecting them to the most appropriate services. And community health workers were key as part of that partnership strategy. So again, just fast forwarding here through the build. The way we had been viewing these types of partnerships with various nonprofits, but including those that employ community health workers, is that we knew that we needed to evolve that relationship from something that was just grant-based or community benefit-based from a financial sustainability standpoint that is obviously very taxing for the CBOs. And as was mentioned before, just ultimately undervalues the types of services and the ultimate value to patients that these organizations provide. And so we're creating a structure essentially to bring community health worker, nonprofits, and then other nonprofits, food pantries, et cetera, into our network so that we can share data more explicitly. We can cooperate together both operationally and financially so that they can participate in the value-based dollars that the pop health contracts bring. That's our ultimate goal. And evolving that using technology that we'll talk about in a little bit, even having a formal credentialing process, having regular operational discussions about how we work together, and really including them. We would like to see ultimately where, whether it's a physician or social worker in our network, can view a community health worker, community-based organization in the same way they might view home health or a SNF or any other, more of say, typical partner in healthcare. That's what we're evolving towards. So we see a joint strategy here that I hope is a useful framework. From the hospital system perspective, COVID highlighted a lot of these issues, but they existed long before COVID. And one is that large systems like Sinai, but others across the country, they really struggle with community engagement for lots of reasons. Ego probably being number one, but number two is the history of large systems with communities is not great. Often the involvement is often limited to time-limited grants or projects without real investment and really any enough, I would say, forward-thinking investments in communities. And that creates a fair amount of mistrust. And so that is an issue that systems need to overcome if they're going to be successful as part of their population health, within their population health efforts. The other pieces I highlighted is that the care management resources that currently exist within systems are usually much less than what is actually required to do this sort of outreach at scale. And so we need help. One of the most concrete ways that we found that was most helpful to partner with community health workers is the not only identification of patients at risk, but then the direct care, the direct interaction to help patients navigate immediate needs because of COVID and then start planning for future needs. So we developed a strategy on that we'll describe here very quickly. And then on the CBO side, on the financial sort of alignment, is that we hope that by partnership within a managed care process, in a partnership within a contract that tries to manage total cost of care and clinical outcomes for patients, that and having a nonprofit like AIR NYC or others partner with us in that way, it creates a financial or a sustainability process that's beyond the typical grant cycle or philanthropy. In order to be I think compensated fairly for the work that's provided, I think it is going to require participation in essentially medical expenditures. Because frankly, I think that it's difficult to imagine that our current policies will ever compensate enough for public health. That would be amazing. But in lieu of that, we have to then divert healthcare expenditures over to really fund a lot of these initiatives. So just briefly here, what we're trying to do in order to have that participation be as robust as it needs to be, we start with data collection on our patients on social determinants, align care plans around social determinant needs, and then we do a reasonable job at those first two things, data collection and alignment of care plans and to include social needs. And we do an okay, although not great job at tracking our referrals to community health workers and other nonprofits for these needs. But historically, systems do a terrible job in collecting the feedback back on what those interventions actually entail and determining ROI. It's helpful, and I'm aware of all the different studies that look at the ROI on community health worker interventions. But unfortunately, when you're speaking like health systems speak, and I go to a CFO and ask for them to invest in some of these strategies, it is still a very difficult conversation, often not terribly fruitful. We feel that by having this technical infrastructure and relationship with the CBOs, we can start doing a better job of getting granular on the ROI impacts of specific interventions, so we know where to invest and where to include that in our strategy. So I'll actually stop there because I know we're way behind on time, and I can sort of address any nuances in the Q&A, but I appreciate everyone's time and attention here this afternoon.
Thank you so much, Rob. And again, please feel free to ask your question by clicking the Q&A button at the bottom of your screen if you haven't asked your question already, and we will do our best to answer as many questions as possible. And for those of you that asked kind of specific questions where you're looking for materials that might have been referenced, we will try to follow up with you after the webinar to connect you with the information that you're looking for. So I'd like to invite all of our panelists to share their video as we jump into some of the questions. Great. So one great question that we just received was, did COVID highlight the importance of community health workers? What adjustments did you make due to COVID that you think may persist because they were popular with clients or because they could potentially improve outcomes? So Rob, Shreya, or Maria, feel free to jump in if you'd like to answer that question.
Did you ask what shift?
Yes, what adjustments did you make due to COVID that you think might stick either because they may improve outcomes or because they were popular?
No, I would say that for us, one of the things I didn't highlight in the talk is that our relationships with community health workers before COVID were pretty vanilla. And I mean, I think even our colleagues, my colleagues from Area NYC would say that, would probably agree that it was mostly on the, I would say, more typical condition management approach. Like he helped us with, you know, at Area NYC in particular, the origins were in asthma and did an amazing job. And that's what our relationship really consisted of prior to COVID. And we had already started conversations to evolve to do more than condition management, but COVID's like fast forward all of that. So now we had more discussions around helping us identify folks at risk for food insecurity, need for medication access, behavioral health issues. We formalized that process and expanded the scope of our relationship a lot faster than we would have otherwise because of COVID. And actually helped introduce a lot of technology. So actually fast forward a lot of efforts on how we might even use text screens and how we actually share data and things like that. All things that were in progress and we had discussed, but sort of fast forwarded all that.
Well, for us, Promotoras have always been the eyes and ears in the community. They've been the ones who know what's going on and who have filtered it back to us and to other agencies. I think COVID has exacerbated their relationship to the community in ways. Since we've gone virtual, they've been very creative in developing ways to sustain their relationship with community, to find out what the needs are, to get it to us and to others, and to get information out, to get resources out. Everything from distributing food to these webinars on emotional wellness and support, financial support. I think that it's kind of stepped up the work that we do, the work that Promotores do, and the urgency in our community. There is also some personal, like a social worker who hears too much, who's always, needs some therapy themselves because they're always listening to somebody. Promotores also have a wellness, need support in that area too. There's a lot of desperation and in our community generally, in particular in the Latino community, as testing is being more offered more and more positives are showing up. There's a lot of emotional support that's needed, and so we've just expanded the resources. And Promotoras are asking for more and diverse resources and support so that they can provide that to the community. So I think COVID has expanded that sphere where maybe it was before isolated or through categorical funding, everything is separated. It now has come together in a real world need. And I find that we're providing more support for Promotoras who provide support for community.
Great, thank you. Then we've also received a lot of different questions about state policies. So I'll combine a few here. A question about what are some of the key first steps for states to lay the foundation to engage community health workers, including policies related to Medicaid reimbursement?
I can take a stab at that if that's okay with my colleagues. So currently, and this is going to get in the weeds, but hopefully it'll be useful. In Medicaid statute, there is a definition of preventive and rehabilitative services that is nice and broad, which is a good thing. It's basically anything that makes you feel healthy, either physically or emotionally, as long as it's recommended by a provider. So pretty much not a lot of strings attached, and it aligns with the, the social sort of framing of health. Then in 2014, there was a reg that allowed unlicensed providers, including community health workers, to deliver those services, and invited states to file state plan amendments in order to avail themselves of that. The problem is that subsequently, so if you just had those two things, a nice broad definition of health and, hey, unlicensed providers, including community health workers could do that, then you would be in good shape to see the kinds of things that I talked about with, Rochelle and Maggie. The problem is that there has been subsequent regulatory guidance that kind of muddled it. Number one, there was a state Medicaid director letter that said, okay, even if you're unlicensed, we need to see all of your qualifications. And I think there is this classism and over professionalization in health, and we are guilty of it ourselves, where we really want to think about the letters behind somebody's name and the credentialing and all of that, and we think we're obsessed with training in healthcare. That's how we, most healthcare professionals define themselves. Community health workers are different. They are defined by who they are, not by the letters that may or may not be behind their name. But when that SMDL came out, a lot of states reacted by saying, okay, now I'm really going to double down on all of these credentialing hurdles, and actually you end up in some cases weeding out some of the natural helpers, and you end up having other people just take the course and become community health workers even though they don't really have that shared identity. So that was a problem. And then the other issue is that in the Medicaid manual, there's a definition of preventive services that's incredibly narrow. It actually goes against the statute definition, and it says this can only be clinical. It's not community or socially based. So all of that is to say, in short, we're having conversations right now with CMS leadership, and they're very broadly supportive actually of scaling up and paying for the workforce in ways that align with the Rochelle Maggie, evidence-based broader story. So if you are interested in your state in doing something like that, I would recommend getting in touch with your Medicaid office, and then feel free to reach out to my team, because we're sort of, as a next step, convening states who are interested in broader scale up of financing for this workforce, and basically understanding what they want to see happen and helping them to develop concept proposals for CMS.
So Logan, I agree with the bulk of what Shiva just said. I think that Medicaid has provided some options, but there are limitations. And for me, it would be expanding it further to beyond the definition and the assistance in Medicaid, but really looking at how that dotted line can go to CBOs, and that dotted line can go to community. As I said before, going to scale is engaging community in that relationship. So then that would allow promotoras to get reimbursed. If the dotted line went to CBOs, then CBOs get reimbursed for. I think there was a misconception when this CMS ruling came out that all of a sudden everybody had to get certified, and the certification is such a broad one that I think people thought that was the panacea. And please, for everybody here, it's not. CMS does not require certification, nor does it require any kind of authority like that. And that's a big discussion amongst us in the community. Some agree with it, some don't, but I think it should be an open discussion in community, and Medicaid should leave it open enough so that community and providers can decide what it is that they'd like to see. But the Medicaid ruling certainly could be an opportunity to engage community and CBOs in that partnership, and then bringing in the promotoras that we talked about, those community promotoras who are already doing that informal work to get reimbursement for it. It would take CBOs out of only relying on soft money and bring in some support.
Yeah, if I could just also quickly say, absolutely, the money needs to flow across sectors in as non-discriminate a way as possible. We will continue to perpetuate inequity if healthcare builds and rather than buys, some of these solutions. Like, you have to pay other sectors to do the work that they've been doing all along. The money needs to flow either directly to community sectors or, through these mechanisms. And then the one way that I think we could really get this wrong, although, in some states this will be the reality, is to have community health workers be fee for service. In a sort of, this is a laundry list of like the things that they do, and then they have to like have billable hours. That I worry that will really kill this, because there's no CPT code for hula dancing to the like, God bless America. And that's the kind of thing that like community health workers need to be able to do. So if whoever's in a position to kind of shape that capitated model that actually has enough dollars behind it is probably the way to go.
So I would suggest, you mentioned foundations, Logan. I would suggest that foundations really take the lead from community. That I think they fall into some of them will fall into the, you know, I'll do whatever the feds are doing, or this is a guideline that states are doing, but really be independent in their thinking and look at what community wants and how it is a community expresses itself. And I think that would be important for foundations to do. Some of them are very progressive in that way, but some are not. And you know, for those of us who rely on soft money, it's a big detriment for funding.
Great, thank you. And I saw, Shreya, that you've been sharing some great resources in the chat box, and others, please feel free to share. I think we did disable the chat box for participants. Maria and Rob, if there's resources that you would recommend, we're happy to share those, and we'll follow up with additional resources to participants as well.
What website? I didn't mention the website. It's Maria, it's visionycompromiso.org, and my email is maria@visionycompromiso.org. Very simple.
Wonderful, and that's on the slide, so so participants will have that. And so we've actually received quite a number of different questions focused on technology and access to technology, especially during the pandemic and the restrictions that are required due to social distancing. So one question asked, what role do you see technology playing in assisting the role of community health workers in terms of facilitating healthcare delivery and access for their patients?
Yeah, I would say, oh, I'm sorry, go ahead. Yeah, I mean, I think this is a huge one. You know, increasingly on the system side, in partnership often means like the tactical infrastructure that is required to communicate effectively, to share data effectively. On the delivery side, as soon as it gets complicated, to have some other sort of outside of the EMR mechanism to interact with somebody that's already creating barriers to partnership. And so we definitely have been working on this. I fear that the space has become really crowded with several venture-backed startups that are trying to, you know, frankly, I think sort of take advantage of the situation here. And I feel like we are dangerously close to repeating the mistakes of electronic medical records about 25 years ago, where we haven't created a standard for how we collect this information, how we share it, and everything's proprietary. And now we've siloed off, you know, patients, essentially, or clients, based on whatever technology they happen to be loaded onto. And so this is what's happened with medical record systems, and we are feeling the issue of that now, or have been for a long time, and trying to go backwards and resolve it. And I feel like there's an opportunity to do something like what North Carolina has done, for instance, and standardize it, at least at the state level. There's actually even more opportunity to do that at the federal level if there was a willingness to do it, but to create some standards now about how we collect and share social determinants information across the board, but then also standards for how that information might be shared with healthcare providers. I think, so, I mean, we're already seeing it in our market. I mean, I know, again, I've had these conversations with my colleagues from Air NYC and a few other places, that they're getting tapped by every system using a different piece of technology. And they're already understaffed, under-resourced, and now being asked to participate in 2, 3, 4 or more different portals in order to be partners with delivery systems. And that's insane. But I do feel like it has to happen at a policy level, and hopefully others will be, you know, as bold as North Carolina and a few other states to create at least some sort of standard.
Great, thanks so much. And I'll note that we have just 1 minute left, where I feel like we could go on and answer these questions all afternoon. So Maria and Shreya, if you have a 10 to 15 second response, feel free, but just wanted to note that we're running up against time.
Thank you for the opportunity to share the Promotor model across the United States, and that exists across the United States. And I just want to encourage everyone to really look to their community and look to their community experts. We certainly are are connected across the United States with the Spanish-speaking community. There are other organizations. There's a national organization also in which I sit on the board. There's a lot of resources, and I would encourage you to look to those resources and to always remember that at the center of social change is going to be that person, that community, and that's who we should focus on. So thank you. Thank you, Logan.
Thank you. And Shreya or Rob, any final remarks as well?
No, thank you so much for having us.
Yes, thank you.
Great. So we'll just have a few more wrap-up slides. We can go back to the slide share. So a lot of the studies that were cited here are also shared on the Better Care Playbook. And so if you have established a promising practice related to this work, if you've published, whether that's a peer-reviewed journal article or a case study on the work that you're doing, we'd love to hear about it. And so we would appreciate you sharing that with us at bettercareplaybook.org. Next slide. And then again, thank you all so much for joining. This is such a rich, valuable conversation, and there's so much to explore. So we'll do our best to follow up with those of you whose questions we didn't get to answer. Thank you so much to our presenters for sharing your insights and sharing about your wonderful work with us. Thank you to the 7 Foundation Collaborative for funding today's webinar. And thank you to all of you for sharing your great questions. Please submit your evaluation survey and have a great day. Thanks again.
Thank you very much.
Thank you.
Adios.